ये मैंने किया।
हाँ है ना
नहीं आ रहा है सर।
हाँ सर।
हाँ it is showing.
हाँ ओके सर।
लाइट शेयर कीजिए।
मैं करता हूँ।
Rohit,
हाँ हाँ
whether it is corrected one or previous one? Corrections made now. We made some corrections now.
Sir, no, sir. I think this one is not. It is the old.
Okay, carry on, no problem.
Dr. Rohit, you can just during the presentation you send the email. We will load from our side. Okay.
Okay, sir.
Okay, present.
You start. Nah, you have to ask Dr. Murtunjay.
Okay. A 54-year-old woman with metastatic breast cancer is undergoing palliative chemotherapy with present during the third cycle with complaints of redness, swelling, burning sensation, peeling of skin over her palms and soles for the past 5 days. On examination, there is a erythema over the pressure areas of both palms and soles with some blisterings. Identify this condition and describe the spotter.
Sir, this condition is known as palmar plantar erythrodysesthesia,
Okay.
which is also known as hand-foot syndrome, and capecitabine and 5-FU are the usual causes, and here it is capecitabine, sir.
Okay. What are the other drugs producing same hand-foot syndrome?
5-FU, capecitabine and 5-FU.
And also cetarabine, liposomal doxorubicin, and docetaxel are the causative agent for the hand-foot syndrome. What are the other names for this hand-foot syndrome?
Palmar plantar erythrodysesthesia.
And acral erythema.
Okay, sir. Acral erythema.
Bergdorf syndrome.
Okay, sir.
Okay. What are the preventive measures you would advise before starting such chemotherapy?
Sir, I would advise patient to avoid friction, pressure, or heat, and I would advise the patient to keep ice packs, and I would advise the patient to use moisturizers and urea-based creams. And I would advise the patient to have pyridoxine supplementation.
Dose?
Sir, 100 mg.
No, 100 mg in divided dose, 50 mg BD.
50 mg BD.
Yes. And also tell her to soak hand and foot in a cold tepid water for a period of 10 minutes.
10 minutes.
Okay. What are the dose limiting toxicities of capecitabine?
Sir, dose limiting. Sir, myelosuppression is the dose limiting.
No. It is diarrhea and hand-foot syndrome is the dose limiting toxicities of capecitabine. Okay.
Okay, sir.
Next. Next slide. Okay. What is this drug? Drug name?
Sir, Vincristine, sir.
Mechanism of action?
Sir, it acts on beta tubulin and prevents. It stabilizes the microtubules, sir, and prevents mitosis.
It's a Vinca alkaloid, inhibits the mitotic spindle formation during the cell division, especially in the M phase.
Yes, sir, M phase.
Indications?
Sir, it is used in lymphoma, Hodgkin's and Hodgkin's and non-Hodgkin's. In Hodgkin's lymphoma, it is used in BACOP regimen.
Yes.
In non-Hodgkin's lymphoma, it will be used. And
what regimen?
Hello.
What regimen name?
Sir, RCHOP regimen.
RCHOP. Okay. What other conditions? Other indications?
Sir, it will be used in neuroendocrine tumors.
Neuroblastoma, Wilms tumor.
Neuroblastoma, Wilms tumors.
And ALL, CML.
Yes, sir.
Kaposi sarcoma.
Okay, sir.
What are the side effects?
Sir.
First, tell dose limiting side effect.
Sir, peripheral neuropathy is the dose limiting side effect.
Good. Other side effects, sir?
Sir, bone marrow suppression and
liver toxicities.
Liver toxicity, sir.
Alopecia.
Yes, sir. Alopecia.
Dose schedule, sir. Dose schedule.
Sir, usually it is used with, 1.4 mg per meter square in Hodgkin's.
1 to 1.4 milligram per meter square. Maximum dose up to
2 grams, 2
2
milligrams.
mg. Okay.
Yes.
Good. Next slide. Next. A 48-year-old woman with stage 3B triple negative breast cancer completed 4 cycles of neoadjuvant chemotherapy with AC regimen, followed by 3 cycles of Paclitaxel. Now presented with progressive shortness of breath on exertion, fatigue, mild ankle swelling, no history of hypertension, ischemic heart disease, BP 110/70, pulse 96 per minute, regular, mild bilateral pedal edema, chest auscultation by basilar crepitations, echo LV left ventricular ejection fraction less than 62%. From 62% to 45%. What is the mostly diagnosis?
Sir, based on the scenario, it might be anthracycline-induced cardiotoxicity.
What
Sir.
anthracyclines we use here?
Sir, usually we use doxorubicin, epirubicin.
In this case,
Doxorubicin, sir.
What are other anthracyclines?
Sir, epirubicin.
Epirubicin.
Daunorubicin.
Okay. Daunorubicin, not anthracyclines. Okay.
Yes, sir.
How can this toxicity can be prevented?
So we can prevent toxicity by doing a baseline echocardiography and monitoring with subsequent in subsequent cycles. Usually we repeat echo in every 200. For every 200 mg per meter square dose, and we can use.
What is the cumulative dose? How you intervene based on the cumulative dose?
We can limit the cumulative dose by 400 to 550 mg.
Okay.
And we can use liposomal doxorubicin or epirubicin, which are selectively less cardiotoxic.
Okay. What is epirubicin?
Sir, epirubicin is also an anthracycline.
What is cumulative dose of epirubicin?
Sir, 900 mg per meter square.
Okay. What are the side effects of epirubicin?
Sir, cardiotoxicity, liver toxicities and myelosuppression.
Okay. What are the Adriamycin dose limiting toxicities?
Sir, cardiac toxicity and liver toxicities.
Myelosuppression and cardiac toxicity. Okay. What is dexamethasone?
Sir, dexamethasone is iron chelator, which is used as a cardioprotective agent in Adriamycin cardiotoxicities.
Okay. What it and a mechanism of action? What it causes? How it will prevent?
Sir, it chelates with the iron. In the presence of oxygen, it chelates with the iron and prevents from free radical formation and
radical formation. It inhibits the oxidative damage to cardiac tissues. Good. Next. What is the name of the drug?
Sir, Gemcitabine, sir.
Gemcitabine. Mechanism of action?
Sir, it is a pyrimidine analog, and it gets phosphorylated inside the cell, and it blocks ribonucleotide reductase, which inhibits DNA synthesis.
And indications?
Sir, we usually use it in pancreatic cancer, non-small cell lung carcinoma, bladder cancer, intravesical therapy also it will be used, and biliary tract.
Breast cancer also.
Okay.
Next. A 26-year-old man is undergoing chemotherapy for stage 2B testicular germ cell tumor with Bortezomib, Bleomycin, Rituximab and Cisplatin. He presents during his fourth cycle with 3-week history of dry cough, progressive dry cough, exceptional shortness of breath, occasional low-grade fever, respiratory rate 20 per minute, and oxygen saturation 92% on room air, chest auscultation, fine bibacillar crackles. No clinical evidence of infection. Chest X-ray shows bilateral reticular opacity predominantly at lung bases. PFT decreased diffusion capacity for the carbon monoxide. What is most likely diagnosis?
Sir, bleomycin-induced pulmonary toxicity, sir.
Bleomycin-induced. Risk factors associated with it? Bleomycin.
Sir, smoking, chronic smoking history, and pre-existing any lung diseases
Okay.
or prior chest radiotherapy.
What are the symptoms of pulmonary bleomycin-induced pulmonary toxicity? Symptoms and signs. Just now we
Sir,
discussed.
cough, shortness of breath, I mean, dyspnea, cough, and fever with infection.
No infection. How dose schedule, sir?
Sir, usually it is used in a BACOP regimen in Hodgkin's lymphoma, and it is used as, 10 units per meter dose it is used, sir.
Okay. First, we have to give some 2 units test dose, wait for 1 to 2 hours, then we have to give rest of the dose. What are the side effects?
Sir, side effects are myelosuppression and
it causes hypersensitivity and hyperpigmentation, anorexia, and mucositis. What a cumulative dose, ideal cumulative dose of bleomycin?
Sir, 400 units.
Yes.
Should be less than 400 units.
Good. Next. What is this drug?
Sir, Olaparib, sir,
Mechanism?
it is a poly-ADP ribose polymerase inhibitor. It inhibits single strand DNA break.
Inhibits the repair mechanism.
It is used to synthesize lethality in case of BRC, BRCA mutations, where homologous recombination is deficit.
Okay. What are other drugs in the same category?
Sir, Rucaparib, Olaparib, and
Niraparib,
yes, sir.
Talazoparib.
Okay.
Indications, sir?
Sir, it is used in BRCA mutated breast cancers or prostate cancers, metastatic prostate cancers.
Dose schedule.
Sir, it is given 300 mg per meter square.
Next. Next question. 63-year-old man with locally advanced squamous cell carcinoma of oropharynx undergoing concurrent chemoradiation with weekly cisplatin. After fourth cycle, he presented with fatigue, decreased urine output, and mild confusion. On examination, BP 135/80, pulse 90 per minute, regular, no pedal edema, mild dehydration. Investigations, creatinine 2.1 increased compared to the baseline 0.9 milligram per deciliter. Blood urea nitrogen 48 milligram per deciliter, serum potassium 5.8, magnesium low, hyperkalemia and hypomagnesemia. Urine analysis, no proteinuria, no hematuria. Which drug in this regimen is the culprit? What are the causative agent?
Sir, the labs show kidney injury and dyselectrolytemia, which are side effects of cisplatin.
Okay.
Cisplatin.
Okay, what are the other side effects, dose limiting side effects?
Sir, emesis, ototoxicity, and
Ototoxicity?
sir, emesis, sir, nausea, vomiting.
Emesis is not dose limiting. Next. Peripheral neuropathy.
Peripheral neuropathy.
Mostly a sensory neuropathy. Okay.
Yes.
Next, how can this toxicity can be prevented?
Sir, we can give adequate hydration pre and post infusion. We can use diuresis, forced diuresis,
Mm.
and we can substitute it with carboplatin or
Potassium and magnesium also that, yeah.
yes, sir. Potassium and magnesium
Mm.
could be supplemented, and we can substitute it with carboplatin in severe kidney injury cases.
Okay, okay. What is the carboplatin actually? What type
Sir,
of drug?
sir, it is a
Carboplatin?
platinum.
Carboplatin?
Hello.
What kind of drug? I mean, what kind of drug? Carboplatin. Which
Sir,
class of drug? Sorry?
Sir, voice is breaking. Sir, can you repeat the question?
Carboplatin comes under which category? I mean, which class of drug?
Sir, platinum group of alkylators.
Alkylating agent. Okay.
Yes.
Mechanism of action.
Sir, it forms
Cross-links.
cross links.
Okay. Okay. Dose limiting toxicity of carboplatin.
Sir, peripheral neuropathy,
Myelosuppression.
myelosuppression.
Mostly thrombocytopenia. Dose.
Okay.
How you calculate the carboplatin dose?
Sir, we calculate using Calvert formulas.
What is
yeah.
that?
Sir,
What is the
area
correct?
under curve into GFR plus 25.
25. Dose in milligrams.
Yes.
Next. Name the class of drug.
Sir, it is a tyrosine kinase inhibitor, sir.
Inhibitor.
It inhibits BRCA and ABL fusion protein.
BCR-ABL.
BCR and ABL fusion protein inhibitor, and also it inhibits platelet derivated growth factor and c-KIT also, sir.
CK means? CK means?
Sir, I can't remember.
Okay. It is a potent selective inhibitor of BCR-ABL tyrosine kinase. Okay.
Yes.
Dose limiting toxicity is myelosuppression. Dose schedules are in CML.
Sir, usually we use it as 400 mg oral.
400 mg.
Oral, sir, OD.
Once daily. Okay.
Once daily, sir. Yes, sir.
In accelerated cases, accelerated CML.
Sir, we go up to 600 mg, sir.
In GIST?
600 mg, sir.
600 mg. Okay. What are the other one in Imatinib category? Other is in Dasatinib.
Dasatinib, sir. Yes.
Okay. It is a multiple tyrosine kinase inhibitor.
Yes, sir.
Okay. But Imatinib is BCR-ABL only that tyrosine kinase inhibitor. Okay.
Okay.
Dose schedules of Dasatinib.
Sir, I don't remember.
100 mg per oral once in a day. Okay.
Okay, sir.
Okay, next. A 59-year-old man with stage 3 colorectal cancer is receiving adjuvant FOLFOX therapy. After his fourth cycle, he reports tingling, numbness, and burning pain in both hands and feet. He also noticed difficulty in buttoning his shirt and odd sensation when drinking cold water. It feels like a pins and needles in my throat. On examination, stocking glove distribution of sensory loss to the light touch and vibration, no motor weakness, reflexes are preserved. What is the likely diagnosis?
Sir, hand, foot, mouth disease, which is caused due to
No, it's not hand, foot, mouth disease.
Peripheral neuropathy, sensory neuropathy due to Oxaliplatin.
Okay. How it can be prevented?
Sir, we can ask the patient not to have any cold items or avoid cold drinks and cold air
Cold,
for
cold
several days
beverages.
after infusion. And we can give calcium or magnesium infusions, and we can monitor symptoms regularly after infusion, and we can reduce the dose.
Okay. How to manage this one once it develops?
Sir, it is a self-limiting, so it will reassure the patient and avoid cold. We'll ask him to avoid cold foods, and sir, we can give duloxetine or gabapentin for neuropathies.
Okay. Next slide. This dose limiting toxicities of Oxaliplatin. Okay.
Yes, sir.
Acute dysesthesias. Next. Name the class of drug.
Sir, it is a steroid inhibitor. It inhibits 17 alpha hydroxylase and 1720 lyase, and it prevents formation of DHEA and dihydroandrosterone and testosterone subsequently.
Indicated.
Sir, it is usually used in metastatic prostate cancer, sir. Both patient sensitive and resistant.
Dose schedules.
Sir, we give 1000 mg orally, once daily, along with prednisolone tablet 5 mg. Sir.
Why you are adding prednisolone to the Abiraterone?
Sir, we add prednisolone because of excessive mineralocorticoid activity due to ACTH, increase in ACTH levels. To reduce that, we will give prednisolone to reduce it through feedback mechanism.
It should be taken in empty stomach or with food?
Sir, it should be taken in empty stomach. Food reduces the absorption.
Okay, next. A 42-year-old woman with primary CNS lymphoma is receiving high-dose methotrexate-based chemotherapy. 4 days after her last infusion, she presented with mouth sores, difficulty in swallowing, generalized fatigue, on examination, multiple oral ulcer with erythematous margins, mild conjunctival pallor, no skin rash, hemoglobin 9.8 gram per deciliter, WBC 2200, platelets 70,000, serum creatinine 1.9, baseline is 0.8 milligram per deciliter. What is mostly likely diagnosis?
Sir, according to the symptoms, patient is having thrombocytopenia, mucositis, and acute kidney injuries.
Okay. Myelosuppression.
Myelosuppression, and it is due to the high dose methotrexate.
Management? How to manage?
Sir, we halt methotrexate and we give hydrations, and we will do urine alkalization, and leucovorin rescue we will give, sir.
Okay. How dosage of leucovorin when compared to treatment doses of methotrexate, how you are giving? Dose schedules like 1 mg leucovorin for 1 mg methotrexate we have to give. Okay.
Yes. Equal.
Equal. Dose limiting toxicity of methotrexate.
Sir, mucositis,
myelosuppression, renal dysfunction. Okay.
Yes. Okay.
When it is contraindicated, when creatinine clearance, when it is
less than 20,
less than creatinine clearance.
Less than 20 ml per minute.
No, it is contraindicated when it is less than 60 ml per minute or serum creatinine value of more than 1.5 milligram per deciliter.
Okay, sir.
Okay. How routes of administration methotrexate? How many types are there?
Sir, it can be given IV
Hmm.
as an infusion, as an intrathecal,
Okay.
orally also.
Just a interruption. Dr. Rohit and Dr. Murtanja, just your voice are not so audible. Please
Okay.
see your mic actually.
Okay.
Okay, sir.
Hello.
Okay. You can continue, but just see mic, the slightly loud voice we need.
Okay.
Okay.
Okay. Next slide. Name the class of drug.
Sir,
Tamoxifen.
it is a selective
Mechanism of
estrogen
action.
receptor. It is a selective estrogen receptor modulator, and it binds to estrogen receptor and inhibits hormone dependent cell proliferation in hormone positive breast cancer.
Okay. What are the it has both anti-estrogen and estrogen activities. Okay.
Yes,
Estrogen effects.
partial estrogen agonist.
Yes. Indicated in?
Sir, it is indicated as an adjuvant treatment in hormone positive breast cancer, also in metastatic hormone positive breast cancer.
Dose?
Sir, 20 mg orally daily, sir, once daily.
Okay. Side effects? What are the side effects?
Sir, risk of endometrial carcinoma and cardiac side effects and
Thromboembolism.
thromboembolism, DVT. Yes, sir.
Next. A 51-year-old man with locally advanced ovarian cancer is receiving combination of chemotherapy with Pacli and Carbo. Within minutes of starting her third Paclitaxel infusion, she develops shortness of breath, flushing, dizziness, and hypotension. On examination, BP 80/50, pulse 120 per minute, regular, oxygen saturation 89%, and room air, diffuse erythematous rash over face and chest, wheezing and auscultation. What is most likely diagnosis?
Sir, it is a hypersensitivity reaction due to Paclitaxel.
Okay. What is what are the other forms of Paclitaxel to avoid these type of side effects? What kind of formulations are available?
Sir, albumin-bound Paclitaxel can be given.
Okay. What are the side effects of Paclitaxel, dose-limiting side effects?
Sir, peripheral toxicities.
Okay. Neuropathy, neutropenia,
Peripheral neuropathy and yes.
hypersensitivity reactions.
Yes.
Okay. What are the causative agent for this hypersensitivity reaction in the Paclitaxel?
Sir, it is the solvent which causes a reaction rather than Paclitaxel itself, and the solvent is Cremophor EL.
Okay. How to manage this hypersensitivity reaction?
Sir, we have to stop the infusion. We have to check for airway patency and maintain the airway, and we have to provide oxygen if it is needed, and epinephrine should be administered, and corticosteroids will be given, and fluids.
Okay. Next slide. Name the class of drug.
Sir, it is non-steroidal androgen receptor antagonist.
Anti-androgen.
Anti-androgen. Yes. It competitively inhibits androgen receptors.
What are the side effects of this one? Bicalutamide.
Sir, osteoporosis, hyperlipidemia, cardiac side effects, gynecomastia.
Impotence.
Hypogonadism. Yes, sir.
Dose schedules.
Sir, 50 mg orally, sir, once daily.
Indicated in
Sir, it is indicated in prostate cancer, sir, metastatic setting, and also as in the combined androgen blockade regimen along with GnRH agonist, sir. Because in the initial phases, GnRH agonist increase testosterone level
yes.
to
Next.
avoid the flare.
Next. Okay. A 52-year-old male with recurrent sarcoma is receiving IA regimen as a part of his chemotherapy regimen. After third cycle, he presents with dysuria, urgency, passage of blood in urine. Urinalysis reveals hematuria with no bacterial growth and culture. What is most likely diagnosis?
Sir, it is hemorrhagic cystitis caused by hypophosphamide, sir.
What other agents causes hemorrhagic cystitis?
Sir, cyclophosphamide.
Cyclophosphamide. Okay. What is the pathophysiology behind this one?
Sir, hypophosphamide byproduct is acrolein, sir, acrolein, which is water insoluble and it gets accumulated in bladder.
Bladder. Yes. What are other causative agent for the neurotoxicity due to the ifosfamide? What compound causes neurotoxicity?
Sir, I can't remember.
No. Ifosfamide compound, acrolein causes hemorrhagic cystitis. No?
Yes, sir.
Like that, neurotoxicity is caused by other compound which released by ifosfamide. What is that one?
Sir, I don't know.
Chloroacetaldehyde, which causes the neurotoxicity due to the ifosfamide. Okay.
Okay, sir.
Chloroacetaldehyde component. Okay.
Okay.
Ifosfamide is indicated in what conditions?
Sir, it is indicated in IE regimen in sarcomas.
Okay.
And it is also indicated in
Lymphomas.
Lymphomas also, sir.
Relapsed testicular tumors. Okay. What are the toxicities? Dose limiting toxicities of ifosfamide, as we discussed already.
Sir, liver failure and
myelosuppression, hemorrhagic cystitis. Okay.
Okay, sir.
How to prevent this one, hemorrhagic cystitis?
Sir, we give Mesna 2 mercaptoethane sulfonate sodium. It will bind to acrolein and reduce hemorrhagic cystitis.
Okay. Dose of Mesna?
Sir, it is given as 400
equal dose of ifosfamide. How? Continuous. If you are giving continuous infusion, how you are going to give Mesna? In IV bolus situation, how you are giving? How you are going to give Mesna?
Sir, in IV bolus, we will be giving every 2 hourly or 4 hourly, sir. In IV, we'll run as long as we run the ifosfamide infusion.
Okay, in IV bolus, we have to give 60% dose of ifosfamide. 50 minutes, 20%, 15 minutes before the ifosfamide IV, and remaining 20%, 4 hours after 20%. 4 hours after ifosfamide therapy, and 8 hours after, remaining 20%, 8 hours after ifosfamide treatment. In continuous infusion?
Sir, equal, dose.
Equal dose, yes. First 20% with ifosfamide, after 2 hours, remaining 40%, after 6 hours, remaining 40%. Okay? That like that, you have to space the Mesna during ifosfamide treatment.
Okay, sir.
Next.
Okay, sir.
Name the class of drug.
Sir, it is human epidermal growth factor receptor inhibitor, sir.
Okay.
It is a monoclonal antibody.
Indicated in
Sir, it is indicated in HER2 positive breast carcinoma, and it is indicated in HER2 positive GE junction tumors for gastric tumors, sir.
Gastric tumors. Dose schedule, sir?
Sir, 3-weekly and weekly dose schedules are followed. In 3-weekly, we give 8 mg per kg IV as loading dose, followed by 6 mg per kg IV, sir, every
Maintenance
3
dose.
weekly as maintenance. And in weekly schedule, we give 4 mg per kg IV as loading dose, followed by 2 mg per kg IV, sir, weekly.
What are the toxicities? I mean, dose limiting toxicity of trastuzumab.
Sir, cardiotoxicity.
Cardiotoxicity. Okay. How you are going to advise after trastuzumab therapy for the cardiac monitoring, and how you are going to assess cardiac monitoring and during and after trastuzumab therapy?
Sir, we'll get a baseline echocardiography and
Okay.
get an echocardiogram after 6 months.
Okay. Every 3 months.
Okay.
Every 3 months left ventricle. I mean, ejection fraction.
Then we have, yes, sir, to monitor ejection fraction.
Okay. Next, what are the antibody drug conjugates in trastuzumab? I mean, HER2-based therapies. What are the antibody drug conjugate?
Sir, Emtansine and sir, another one is TDM. TDM one is Emtansine and DXD deruxtecan something.
Okay. Yes, sir. Deruxtecan. Trastuzumab deruxtecan. Next. A 62-year-old male with multiple myeloma on chemotherapy with bortezomib, lenalidomide, and dexamethasone. After his third cycle, he develops painful grouped vesicular eruptions over right back in dermatomal pattern. He reports burning and tingling sensation for 2 days prior to the rash appearance. What is most likely diagnosis?
Sir, herpes zoster infections.
What is the mechanism behind
Sir,
this?
Bortezomib causes T cell mediated immunosuppression by inhibiting 26S proteasome.
Okay, how it can be prevented?
Sir, it can be prevented by giving prophylactic trimethoprim and sulfamethoxazole tablets, 400 mg twice daily. Or sorry, sir. Sir, it is prevented by giving acyclovir, sir. Acyclovir 400 mg BD and valcyclovir 500 mg.
What is this regimen? As I discussed, bortezomib, lenalidomide, dexamethasone, used in
Yes.
multiple myeloma.
Multiple
it's a VRD
myeloma.
regimen. Okay.
Yes, sir. Yes, sir.
Okay. Bortezomib, what are the other indications bortezomib used in? Indicated in?
Sir, I don't remember.
Okay. Mantle cell lymphoma, multiple myeloma.
Okay.
Lenalidomide, dose schedules of lenalidomide. What is lenalidomide?
Sir, I don't remember the schedule.
Okay, it is a thalidomide analog, immunomodulator.
Modulator, yes.
Okay. Dose schedules are usually 25 mg capsules, day 1 to 14 per 21 days cycle.
Okay, sir. Okay.
Next, please. Cetuximab, mechanism of action.
Sir, Rituximab inhibits EGFR, epidermal growth factor receptors, sir,
Okay.
and prevents down signaling pathways and cell proliferation.
Indications, sir?
Sir, it is usually used in head and neck, substituted in head and neck cancers head and neck squamous cell carcinoma, and colorectal carcinoma who are
Metastatic colorectal carcinoma.
metastatic colorectal
Refractory to
carcinoma. Sir,
metastatic colorectal carcinoma refractory to the primary treatments.
primary, yes, sir.
What is the toxicity, dose limiting toxicities?
Sir, rash, hypersensitivity,
Anaphylaxis, infusion-related
yes, sir.
hypersensitivity reactions. Okay.
Yes, sir.
Okay, you have to monitor the magnesium levels during and after treatment, Cetuximab.
Okay, sir.
Dose schedule.
Sir, initial loading dose is given as 40 mg per meter square IP, and maintenance is given as 250 mg per meter square, sir, weekly.
Okay. Next. A 54-year-old woman with newly diagnosed GBM undergoes maximal safe resection, started on concurrent radiotherapy with temozolomide, followed by adjuvant temozolomide. After 4 weeks of treatment, she presented with fever, dry cough, progressive shortness of breath, hypoxia, chest CT suggestive of bilateral ground glass opacities. What is the most likely diagnosis?
Sir, it is pneumocystis jirovecii pneumonitis, sir.
Pneumonia. Okay. How it can be prevented?
Sir, it can be prevented by giving prophylactic, trimethoprim sulfamethoxazole tablets.
Double strength.
Double strength, sir, yes, sir, DS.
What is temozolomide will come under what category? And
Sir, oral alkylating agents.
alkylating. What is mechanism of action? What
Sir,
alkylating agents cause usually? Mechanism of action.
Sir, it is converted into MTIC, monomethyl triazine iodocarboxamide, alkylates, O6 guanine.
Methylates guanine residue.
Methylates O6
Usually,
guanine.
alkylating agents like cisplatin, carboplatin, they form crosslinks.
Yes, sir.
Okay, but it won't form crosslinks and okay.
Okay, sir.
Okay, due to its lipophilic activity, it crosses the blood-brain barrier. Dose limiting toxicities of myelosuppression. Dose limiting toxicity. Temozolomide is myelosuppression.
Suppression, yes, sir.
Dose schedules are in the during radiotherapy and adjuvant setting.
Concurrent and adjuvant setting. Concurrent setting, we give 75 mg per meter square orally once daily for 6 weeks along with radiation. And adjuvant, we give 150 to 200 mg per meter square orally once daily every 5 days in 28-day regimen for 6 months to 1 year.
Okay. First, initially, we'll start with 150 milligram per meter
150
square.
milligram.
Based on the tolerability, we will shift to 200 milligram per meter square. Okay.
Yes. Okay.
Next. Rituximab, mechanism of action.
Sir, it is CD20 monoclonal antibody which acts on CD20, and it causes B-cell depletion by component mediated or antibody dependent cellular cytotoxicity.
Okay. Indications.
Sir, it is indicated in non-Hodgkin's lymphoma, sir, R-CHOP regimen.
R-CHOP regimen, and also in CLL. Okay.
CLL, yes.
What are the autoimmune diseases? Other indication.
It is also indicated in some non-malignant autoimmune diseases like rheumatoid arthritis and microscopic polyangiitis.
Okay, next. Special instruction. What you will proceed during administration to Rituximab?
Sir, it usually causes hypersensitivity reactions, so we give pre-medications like antihistamines and corticosteroids, and we monitor the infusion and also we screen for hepatitis B because it reactivates hepatitis B.
Dose schedule of rituximab.
Sir, 375 mg per meter square.
Square. Okay. First, we have to give 50 milligram per hour. Check for any reactions, and then you can continue with the
Then
400 mg per hour. Okay.
yes. Okay.
Because it's anaphylactic, I mean hypersensitivity reactions. No? That's why.
Yes. Okay.
What are the other side effects, dose limiting side effects other than hypersensitivity? Cardiac arrhythmias.
Sir, sir, I can't
Cardiac
hear.
arrhythmias.
Okay, sir.
Okay. Next. 46-year-old woman with stage 3B breast carcinoma on adjuvant chemotherapy with AC regimen. She presented with fever, chills, mild fatigue. On examination, BP 110/70, pulse rate 102 beats per minute, respiratory rate 18, SpO2 98%, CBC, WBC 600, absolute ANC count 300. What is your diagnosis?
Sir, febrile neutropenia, sir.
What is febrile neutropenia?
Febrile neutropenia is defined as fever recorded about 38.3 degrees centigrade or fever recorded above 38 degrees centigrade for more than 1 hour, sir. And lab showing absolute neutrophil count less than 500 per microliter or anticipated to go below 500
Okay.
cells
How
per
you
microliter.
manage?
Sir, usually we isolate the patient and follow barrier nursing, and we assess for any signs of sepsis. Then we take blood cultures from one from peripheral and one from central, if central line is there, and we will, respectively take urine, sputum, wound cultures depending on the situation, and we give antibiotics. We'll start antibiotics. Usually, we give piperacillin tazobactam and third generation cephalosporin cefepime. And we try to give support. GCSF also we will give, sir, to increase neutropenia.
Antifungals also you have to add.
Antifungal.
In high risk cases, we have to go for meropenem IV antibiotic, higher antibiotics. Okay.
Okay, sir.
Okay. Next. Crizotinib mechanism.
Sir, it is also a tyrosine kinase inhibitor. It inhibits ALK and ROS.
What is ALK?
Tyrosine kinase. Sir, anaplastic lymphoma kinase.
Okay. Indications.
Sir, it is indicated in metastatic non-small cell lung cancers, ALK positive, and anaplastic large cell lymphoma, ALK positive.
Okay. Dose.
Sir, 250 mg per, 250 mg orally, sir, once daily.
Twice daily.
Okay, sir. Okay.
Next. Next. Next slide. A 45-year-old male with bulky high-grade DLBCL. He started on his first cycle of R-CHOP chemotherapy, and day 2 post-chemotherapy, he presented with generalized weakness, nausea, muscle cramps, decreased urine output, BP 110/70, heart rate 105 per minute, febrile. Potassium 6.2, hyperkalemia, hyperphosphatemia, uric acid, hyperuricemia, hypocalcemia, creatinine more 2.1 milligram per deciliter. ECG suggestive of peak T waves. What is most likely diagnosis?
Sir, tumor lysis syndrome.
Tumor lysis syndrome. Okay. What are the laboratory findings of tumor lysis syndrome?
Sir, we usually find uricemia,
Mm,
uric acid more than 25% of its upper limit, that is 8 milligrams per deciliter,
mm,
and potassium over 25% of its upper limit, that is 6 millimoles per liter.
mm.
And hyperphosphatemia, 25% more than its upper limit, that is 4.5 milligrams per deciliter.
Okay.
And hypocalcemia, sir, less than
Only
20.
calcium is low,
Yes,
hypocalcemia. Okay.
yes,
Rest of all hyper. Okay.
yes.
Okay.
And according to Cairo Bishop criteria, more than 2 lab findings should be
When
positive.
you will get these type of tumor lysis syndromes?
Usually highly active or bulky disease.
Okay, and also you are treating
Following
like
by
tumors like
treatment.
lymphomas, leukemias,
Lymphomas, leukemias, which are highly sensitive to.
multi-resonance schedules. But management, how you are going to manage this one?
Sir, will manage by giving hydration 2 to 3 liters per meter square per day. And we try to correct this electrolytemia by giving calcium gluconate.
Hyperkalemia.
For hyperkalemia, we give insulin and D5 infusion or beta agonist. If it is then still refractory, then we will use dialysis.
Dialysis. Okay. Okay.
To revert hyperuricemia, we use resburicase.
Okay.
And for hyperphosphatemia, we use phosphate binders. And calcium is usually not replaced because it will precipitate the phosphate.
Precipitation, calcium and phosphate precipitators.
Yes, sir.
And also soda bicarb to alkylate the
Alkylate urine. Yes, sir.
Next. Imatinib mechanism of action.
Sir, it is a tyrosine kinase inhibitor. It acts against EGFR tyrosine kinase, sir, especially T790 mutated.
T790 mutation. Okay. Indication,
It
sir?
is a small molecule TK which crosses blood-brain barrier.
Okay. Okay. Indication, sir?
Sir, it is indicated in non-small cell lung carcinoma, which is EGFR positive, especially for T790 mutation. Both as adjuvant and in metastatic settings.
Dose schedule, sir?
Sir, 80 mg orally once daily, sir. For
Until
3
the
to 5
disease
years in yes, sir. Adjuvant 3 years and metastatic setting till progression.
Okay. Okay. Next. Letrozole. Is the
Sir,
mechanism?
it is an aromatase inhibitor. It inhibits aromatase enzyme and prevent conversion of testosterone into estrogen, sir, in peripheral tissues. It is used especially in postmenopausal women. And it
Hormone
doesn't
receptor
have
positive breast
agonist.
cancer.
Yes, sir. It is used in hormone sensitive breast cancers. In adjuvant setting and also in
Metastatic setting.
metastatic setting
And
in
also
post
adjuvant
menopause.
extended therapy after tamoxifen.
Yes.
Dose schedule, sir?
Sir, 2.5 mg orally once daily, sir.
Okay. Other aromatase inhibitors?
Anastrozole, sir.
Dose?
5 mg once
1
daily.
mg. 1 mg.
Okay, okay. Sorry.
Other one? Exemestane.
Exemestane.
Okay. These letrozole and anastrozole are competitive inhibitors of aromatase, but
Okay.
exemestane is permanently bound to aromatase. Okay. The
Okay,
dose
sir.
schedules of exemestane is 25 mg
Okay, sir.
per oral body.
Okay, sir.
Next. Geftinib. What is this mechanism of action?
Sir, it is a tyrosine kinase inhibitor which acts against EGFR tyrosine kinases. It is generally given in I mean, non-small cell lung carcinoma positive with EGFR mutation.
Okay.
It especially acts on, I mean, in exon 19 and 21 mutations.
Okay. Exon 19 deletion and exon 21. Okay.
21 mutation.
Dose schedule, sir.
Sir, 250 mg orally once daily until progression.
Okay. What is Erlotinib?
Sir, Erlotinib is also the EGFR inhibitor.
Tyrosine kinase inhibitor. Okay. Same exon 19 deletion and
19. Yes.
Okay. Dose schedule, sir. 150 mg once daily. Okay.
Yes. Okay. Sir.
Before food. Okay.
Okay, sir.
Next. Okay. What is this one?
Sipuleucel-T is an autologous dendritic cell based immunotherapy, sir.
Okay.
It's
It's a cancer vaccine.
a cancer vaccine. It is prepared by extracting peripheral blood mononuclear cells and sensitizing it with fusion protein P8-2024. It consists of prostatic acid phosphatase and granulocyte macrophage colony stimulating factor. After activation, the dendritic cells are extracted and infused to the patient.
Causes the T cell mediated
T-cell mediated cytotoxicity.
indications and
Sir, it is used in castration-resistant metastatic prostate cancer, usually used in asymptomatic or minimally symptomatic patients, and contraindicated in visceral mets.
doses.
Sir,
It will be given. I mean, dose schedule. How frequent you are going to give this vaccine?
sir, thrice weekly.
3 doses they have to give. 2 weekend.
Okay, sir. Okay.
Next. BCG. What is the mechanism action?
Sir, it is a live attenuated Mycobacterium bovis strain. It is a vaccine, and it is given as an intravesical therapy post TURBT. I mean, it triggers local immunity, sir. Both T cell and also it triggers dendritic cells, and also it releases cytokines like interferon alpha, interleukin 2.
Okay. Indications, sir?
Sir, non-muscle invasive bladder cancer post TURBT.
Dose?
Sir, one vial in 50 ml saline will be instilled and kept for 1 hour. Once weekly for 6 weeks, followed by maintenance of maintenance weekly weekly in 3 weeks for on 3rd, 6th, 18th, 24th, and 30th month.
Next.
Not clearly audible. Just clear. Check the voice.
Okay. Leuprolide acetate, mechanism of action.
Sir, it is gonadotropin releasing hormone agonist. Sir, it acts by inhibiting gonadotropin hormone receptors. Initially, it will increase luteinizing hormone and follicular stimulating hormone, and it will have an agonist effect. And after that, it will inhibit continuous administration will down-regulate the receptors and inhibit testosterone production, which will and FHS secretion, which
testosterone and
reduce
estrogen
testosterone
production.
and cell proliferation due to testosterone.
Okay. Indication, sir?
Sir, it is indicated in as combined antigen blockade in prostate cancer, sir.
Okay.
And it is also indicated in hormone positive breast cancer
Okay.
for ovarian suppression and
With
in benign
benign conditions.
sir, fibroid and precocious puberty.
Okay. 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 It should be given with anti
Yes, sir.
androgens 7 days before GnRH analogs, and we have to continue anti-androgens. We have to continue up to 5 weeks after GnRH analog therapy. Leuprolide therapy. Okay.
Okay.
You
Okay,
have
sir.
to start the anti-androgen 7 days
1
before.
week before. Yes.
Okay. And you have to continue 5 weeks
After.
after that. Okay. Dose schedule, sir.
Sir, it is usually given, it is a depot preparation which will be given as IM. Monthly and 3 monthly doses are also there.
Mostly we are
7.5,
giving 22.5 mg every
22.5,
3
3
months.
monthly. Yes.
Next.
Sir, it is also a
Gossamer also
gonadotropin.
same class of drugs.
Same thing.
And what are side effects of goserelin and leuprolide?
Sir, initially in prostate, it will cause flare and it will, side effects are osteoporosis, bone related events, and cardiotoxicities, gynecomastia, hypogonadism,
Mm.
erectile dysfunction.
Yes.
Uh,
Okay. Dose schedule, sir.
Sir, 3.6 mg monthly or 10.8 mg 3 monthly. I am.
Indications are same. Okay.
Yes, sir. Same.
Same as
Breast cancer.
leuprolide.
Yes.
Is there any other? Okay. Patra, sir. Patra, sir. Thank you. Thank you, everyone.
Thank you, sir. Thank you.
Thank you. All the best for your exams.
Thank you, sir.
Thank you, Dr. Murtyunjay Rao, sir.
Thank you, sir.
Thank you, and Dr. Rohit.
Thank you, sir.
Thank you. I think all things, most of the drugs we have discussed so nicely. And the second thing is that there is a, I have discussed about the DNB exam, how to appear and everything. So there is a already delay by more than 20 minutes. No problem, nothing to worry. Tomorrow also good presentation is there. Before starting, I will take 10 minutes class, how to attend the DNB curriculum and everything. Nothing to worry. Tomorrow, be attentive. Tomorrow I will start. For today, we will close the session. Okay. So tomorrow we will plan. Thank you very much. We can close the session. Thank you very much.
Thank you. Thank you.
Over the clarinet, they can close the session. Over to the clarinet, they can close the session, or everybody can leave the
So thank you so much everyone for joining this session. Clearnet is really glad to have all these brilliant people together. So with all your permission, I'm closing the session for today. Thank you.